Hello and welcome. My name is Nicole Mollenkoff, and I have shared a short summary of my professional background at the end of these slides. The title of my presentation is Usability Testing. This is the relevant financial relationship disclosure for this presentation. And these are the learning objectives that will be addressed during the presentation. And these are the key abbreviations that will be used throughout the presentation. Finally, these are some key definitions for terms that I will use in the presentation. So let's start with a self-assessment question. What kind of issues might be discovered by utilizing usability testing during a safety analysis? When we return to the question, I will provide the answer and discuss the rationale. All right, so let's start by discussing a safety issue. So I was in a root cause analysis, and we were talking about a baby who was on ECMO who had been receiving heparin to heparinize the circuit, the ECMO circuit. And at the bedside, the respiratory therapist was managing the heparin drip for that circuit, which is standard practice where I work, and was using bedside ACTs, was testing, the blood every hour. Over an 8-hour time period, the ACTs dropped precipitously all the way to baseline, despite the fact that the heparin drip was being titrated throughout that that time frame. It wasn't until shift change that the nurses realized, and the other RT realized, that what had actually been being titrated was indeed a different drug. It was dexmedetomidine, a sedative, and not heparin. So this, of course, explains why the ACTs had dropped. Luckily, the patient was okay. We still did a root cause analysis just for, the risk in that process that could have ended with tragic consequences. Now, one of the things that came up in the root cause analysis was nurses saying, well, you guys always send us syringes with upside down labels. These are really hard to read. It makes it difficult to program the pumps. And in this case, that was actually a factor. I mean, certainly it wasn't like a root cause factor, but it was a factor that the label was quote unquote upside down. I replied to this and said, "What? We don't put labels on upside down. What are you talking about? That's not something that we would do." And so, when I stepped back from that, I realized that it is actually possible for the labels to be kind of quote unquote upside down. All right, so you can see here how a label might appear upside down when the syringe is loaded onto the pump. The pumps load from the right, and if the technician is holding the syringe in their left hand and labeling, when it's loaded, it's going to appear upside down. So after asking more questions and going to the PICU, I discovered that this is something that was happening pretty regularly. And it's not that our staff was doing this on purpose. It's not that they really didn't realize there were downstream effects. Furthermore, we had no standard labeling expectations. So there wasn't one expected way of labeling these syringes. And as you all know, when there isn't a standard, then there's probably a lot of variation. Some of that variation might be good variation, might be associated with good practice, or maybe safe or efficient practice. And sometimes that variation can be associated with problems like what we saw here. The other thing I learned when I was walking around the PICU looking at syringe pumps and syringes that were loaded onto these pumps is that there were other issues. One of the big issues was that in some cases I saw syringes with no label on them at all. And when I talked with the staff about why the label was ripped off of the syringe, and usually it was there, it was kind of stuck to the pump. But when I talked to them, they said, well, when you look at this pump, there's this gray clamp, that clamp has an embedded laser eye, and that laser eye actually reads the syringe and determines the volume, because when the part of the programming process is to know the size of the syringe, which is important for how the syringe is pushed and actually medication is delivered. But even in this picture you see here, if there is a label obstructing that, sometimes the pump just won't recognize the syringe and they're unable to program the pump. And so the nurses would have to remove the syringe and like I said, stick it there, and hopefully it wouldn't fall, or if there was an issue, they would be able to see what was actually in the syringe. Clearly not a good idea, right? So we knew we had some work to do. In this case, there were other things going on. I'm not sure that the root cause here was the label was upside down, but it certainly didn't help, right? Made things difficult, made it less likely the end user would actually do the right thing, meaning like read the label, maybe even increase workload to some extent. But we know that there are human factors methods that we can use to identify these kinds of problems and address them. So in the last lecture, I talked about the components of usability and, thinking about the syringe labeling process and or the pump loading and programming process. There are certainly interface design issues that are impacting usability. Certainly error reduction. If none of the rest of these, certainly error reduction is impacted. But I would say maybe satisfaction, efficiency could be impacted, maybe even memorability. So as I mentioned, there are two primary types of usability evaluations: heuristic evaluation and usability testing. In this lecture, I'll review usability testing, or sometimes it's called user testing. And so with usability testing, this is an observational method that assesses actual user interactions with an interface. That interface could be a tool, a task, a technology. So it could be, maybe at the interface of a checklist, or it could be a technology like the syringe pump, or a task like labeling a syringe, right? So these are all places where there's an interface, and we could look at users performing at that interface and assess what are the interactions like, what kind of problems are being created as a result of the design. We can look for opportunities to improve that design. We can learn about how end users behave, right? What are their preferences? What do they like? What do they dislike? What's their actual behavior as they interact with that interface? These are really useful for evaluating safety interventions before you actually kind of deploy a final design into the field. So a lot of times kind of in the prototype step, we'll do some user testing. But really what this comes down to is you're doing some sort of simulation with the end user, and you're observing how those end users interact with the system. And almost always we're measuring. We have several things that we'll be measuring to try to determine how well that system fits the needs of the user, right? And when we look at the design, we want to know, is it efficient? Does it have a high mental load or a high physical workload? Is it error prone, right? So, in the case of our syringe labeling, because of the way that's labeled, when we look at the nurses actually loading the syringes onto the pump, we see that, it can lead to different types of errors. There are numerous usability testing examples that are published in the literature specifically around the medication use process. So if this is something you're interested in, you could have a lot of reading on this topic, and you'd get lots of ideas of how you might be able to implement this into your medication safety practice. Just some that I'd like to mention, and I will go through a couple examples as well. Code cart design, I don't know, probably 5 or 10 different publications on this. IV pump design, I'll talk about this. Again, several publications on this. Tool design, so the design of a checklist, the design of a memory aid, the design of an order set, the design of education or an operational method sheet. These are all great places where you can assess the usability of that tool by by using usability evaluation. Another one that comes to mind is one that is used, a usability test that involves a C. diff bundle. So it's a checklist for that, treatment of C. difficile or prevention of C. difficile. And it does user testing with environmental services workers. So, all different examples of how usability testing can be implemented to improve workflow design in healthcare. And again, lots of those examples around medication safety. So one other thing to keep in mind about usability testing is it is considered the gold standard for evaluating safety in clinical systems and devices. So the FDA does have requirements around applying human factors and usability engineering to medical devices. So there is industry guidance for this. Now, not that, for those of us that work in the hospital setting, you may be thinking, that's interesting because I come across a lot of different devices and technology that has a lot of problems in it. You got to think about, at that level, the testing is more basic. It's in a, maybe low fidelity environment. It's not in the actual ICU, for example. And they may not really be using actual end users, but they are required to assess for basic design issues and perform usability testing in that realm before those products come to market. There's also standards. So the International Standard Setting Organization has some standards around the application of usability engineering for medical devices as well. So there are some standards out there that you can take a look at. I'd like to talk about the usability testing process because I think all of you could use this in your practice. I know when I was working as a medication safety officer, I used usability testing quite frequently, and currently I'm a patient safety specialist, and we use usability testing probably every week. We're testing something, whether it's the EHR or a pump or a device or education documents, checklists, you name it. We've probably done some usability tests on it. So I think this is a really great strategy, and I think from the perspective of improving medication safety, it really holds a lot of promise. So for a usability test, first of all, we need users, right? So that's really what separates usability testing from heuristic evaluation. In usability testing, we have end users, and they will actually use the technology or the tool, or they'll perform the task, whatever it may be. They will operate at that interface, and a trained observer will then assess the design of that interface based on data that they collect. So they'll develop a test scenario, and they'll observe, they'll listen, they may also interview the end users. They're going to collect data on the process. And so when you think about, I guess, first of all, who are the end users? They've got to be representative. So if they're, testing like how to program a pump, you've got to have actual nurses, right? You can't just have a bunch of managers that don't really program the pumps. So you want real people that actually use that technology or perform a task at that interface, for example. You want them to be kind of multiple layers, right? You don't want all novice people or all experts. You certainly want kind of some variation. Definitely people who have used that device or technology or checklist or whatever interface you're testing. You want people who have used it before. The next question is, like, in what setting? So what's the clinical use the clinical context for the use of that product? Can you test the actual device or system, or are we testing more of a prototype? I've done this. I've tested prototypes where, for example, we were moving to a new clinical building, and we were moving from a cart to a server model. And so we actually built lots of different versions of the server. So we built prototypes of the server, and then we had nurses utilizing those servers, and we observed, uh, how easy was it to use? Could they find what they needed? How long did it take, to like find what you needed? Their satisfaction. We also tested the technicians delivering those projects or those products. I'm sorry, but again, we just had a prototype. So how high fidelity is the product and the scenario? It can be very low fidelity, all the way through to studying in an actual ICU with actual devices, etc. But it's really important that to every extent possible, we represent the actual complexity in that task, or at that interface. As much as we possibly can, we want to replicate that. As I mentioned, the observer, or the person administering the usability test, is going to design the scenario. This is really important to make sure we're designing scenarios that make sense, that help us find out what we really want to find out. They're rigorous, they're able to provide useful, unbiased information. They're as realistic and real world as possible. Maybe we test like a variety of different endpoints. Might be kind of open-ended, kind of an open-ended process where we're just observing and kind of collecting what we see. In many cases, the field observations might have to happen first. So what that means is the observers, or the person running the usability test, may need to go out and kind of collect some pre-data, really kind of look at, well, what's going on, and then use that pre-assessment to develop the scenarios. Because what you don't want to do is get your users, you got to pull them out of workflow, get them to come do the usability test. And when they get there, they're like, yeah, this doesn't make sense, or, this is not very realistic. And that would be a problem for wasting clinician time. So usually we have a human factors expert that kind of helps facilitate the process, or a medication safety expert that's trained in human factors principles. We'll develop the scenarios based on kind of standard, guidance for how you develop a usability scenario. We'll get some feedback, do some field observations, get some feedback from clinicians, and then package up the scenario, and then recruit the end users. And we will, actually kind of implement that user testing. Generally, these are done with, somewhere in the neighborhood of 7 to 10 users minimally. Sometimes we do even more. We were assessing IV pumps when we were purchasing a new pump fleet, and we tried to target 30 or 40 end users, because we wanted people from all over the hospital. So it really depends on what you're testing, how many users you need to complete your test. What else? So performance data. So you want to gather feedback, both observational as well as feedback from the end user. So we kind of have different ways of doing this. Could be qualitative, could be kind of a think aloud. Maybe you ask the person performing the task to just kind of talk through what they're doing, maybe in more of an open kind of exploratory fashion. More loose is kind of the downside of this. Can maybe introduce some variation in the data that's collected, can make it a little harder to compare data, but there certainly are scenarios where that makes sense. Another thing that is commonly done is quantitative analysis. So there could be a script, there's kind of close-ended, very specific questions, clear endpoints. There may be specific data like time on task, or errors, or points of confusion. Sometimes we even embed probes into these usability testing. So for example, maybe we embed errors into the scenario to see if they're recognized. We could measure task completion or task success, user satisfaction. As I mentioned, a lot of times we'll do an interview no matter what to get some feedback from the end user. But ultimately, the question is, what are you trying to achieve? What are you trying to learn? And your data collection, your performance data that you collect, really needs to, be reflective of that. So again, that user feedback is important. The other thing I didn't really talk about, if you look at this picture, I also have a camera up here. Sometimes we also use cameras in usability testing. This is definitely a gold standard. We can use the camera to make sure that we've properly collected the data, but also sometimes technologies like eye tracking technology, like where is the end user looking for information. That's just, another example of how the recording of these usability testing processes can be useful. So I already mentioned metrics, but fundamentally, like what we want to know is it user friendly? And so there are a variety of ways to assess that. One of which, of course, is just feedback from the end user. But as I mentioned previously, we also look for points at which the end user becomes frustrated. Maybe they get stuck in a part of the task and can't find their way out, or maybe it's kind of a dead end and the process won't continue. So certainly looking for those and quantifying that. The quality of the information that's provided to the end user, the display characteristics. Some of these are maybe reminiscent of kind of how a heuristic evaluation is done, but we're not just looking at what the experts think, we're looking at what the end user thinks. So, some of this comes from the user feedback. Data entry points, maybe collecting data through how the data entry process is carried out. Again, performance, productivity, as I mentioned, and just overall, how easy is it to use. I have a couple examples that I'll share. So this is the example that relates back to the syringe pump. So, again, we've got that syringe pump that has the syringe that's got the upside down label on it, or maybe it's got the label that's been totally ripped off because that laser eye wasn't able to read the syringe. And so we did a pretty extensive usability test on this. First of all, we developed our goal for the project. We wanted to develop a standard method for labeling IV syringes that was not time intensive or difficult for pharmacy staff, but also allowed for efficient loading of these syringes on the syringe pump so that the label is easily readable while loaded on the pump without, obviously without the need to rip that label off. So for this project, our users were nurses and pharmacy technicians. So, clearly before we got those nurses and pharmacy techs together, we had to do a lot of kind of background work. One of the first things we did was we had pharmacy technicians get, I think we had like 100 plus syringes of all different sizes and hundreds of labels. And we had the technicians label those syringes, and we watched that process and collected data on that process. What was kind of the quickest way, what was the easiest way. We did some evaluations, feedback from the end user, from the techs, to learn about, why did they do things a certain way, and really trying to figure out what is the best way to do this. Now, that would only be half of the story, though. The other half of the story is watching nurses take those syringes and put them onto the pump. So, we had those 100 plus syringes, and we had like 4 or 5 nurses, and we had the nurses put all the different syringes on the pump. And for this, really what we were looking at was task completion, right? Like, could they complete the task reliably and efficiently? So could they program the pump with the syringe as labeled? And if so, was it readable? And so that, knocked out maybe a quarter of the syringes we had just couldn't even be put onto the pump accurately. And then we had what was left. And through that, evaluation, having the actual syringes, the labels, the syringe pump. We did this, by the way, in one of our spare pharmacy areas. It wasn't in use at the time, so we didn't actually do it on a nursing unit. But, maybe not quite the realistic scenario. There weren't alarms going off and patients with call bells and all that kind of stuff. But still, pretty reasonable, pretty high fidelity for the most part. Again, the different scenarios we had. The first part with how to label the syringes, and the second part with how to load and program the pump. And like I said, we looked at errors, we looked at feedback primarily. So those two things. There wasn't so much a time element to this because, we did track that, but what we found was the only time that the time really became a problem was when the laser eye wasn't reading, and we just excluded those out of the gate. Like once we found that certain syringes were unable to be loaded, those processes just got eliminated altogether. But we did observe for errors, and we obviously looked out for that need for the nurse to remove the label. We did more of a kind of what you would call just like a think aloud approach where the nurses were just verbalizing what they were thinking. So they verbalized their frustrations. They, talked about, well, like, oh, this works really well, that this was quick versus, well, this is not working. And, maybe it's fine that it's loaded this time, but I worry that it's not going to load every single time, because of the way it's labeled. And, again, so ultimately we looked for the method that had the fewest errors and the fewest frustrations. And so, that day that we did this usability evaluation, I don't know, it probably took a couple hours. We didn't make a decision that moment. We considered all the findings. We consulted with others, both our lead technicians. We took some of these findings back to our pharmacy staff. And ultimately, we developed a process for the pharmacy and vetted that with nurses on our group. And then we ultimately developed a standard work process. And so this is what that looked like. So we unfortunately, despite our best efforts, we ended up with two different processes. So, because of the size of the labels that we were using at the time, we had this flagged syringe, which you all know is maybe not the most ideal way to do this, but we did that for the smaller syringe sizes, and then for the large syringe sizes, we were able to have the kind of horizontal orientation. But basically, we created this standardized method. Clear, concise, simple instructions. These operational method sheets were posted in all of our IV production areas. Everybody was retrained, and we audited this process over the, I don't know, maybe over the first month or so, and almost no issues at all. I mean, because we had engaged the frontline staff, because the techs were part of the process, the lead techs were part of the process, even some of our pharmacists that routinely check in the production space were part of the process. It really was a pretty smooth sailing project, and ultimately the nurses were very happy. Here's another example, epinephrine injector for patient use. Now, I have to be honest, when I first heard about this case, I was at a human factors conference and I was being educated on human factors and patient safety by one of my mentors, John Gosby, who is a physician who is very talented and a human factors expert. And so I remember, first kind of hearing about usability tests with epinephrine. And then, ultimately, we kind of built this into some training that we had for students who were doing medication teaching. And so looking at this example, the design goal here. So what's our performance goal? What do we want to ultimately achieve? We want a regular person, a lay person, but certainly, a pharmacy student, or a nursing student or a nurse to be able to use an epinephrine auto-injector in an emergency situation without prior training. The problem is the devices at the time when we did this, they were, maybe like the first or second version of those devices, and they were pretty error prone. It wasn't really obvious how to use it, even though it should be. And there were lots of reports of problems, including at our hospital. And so in this usability test, we would do this with pharmacy students as well as nursing students, and we would use trainers, obviously. So, we had epi auto injectors they didn't have needles, they didn't have actual drug in them. So we would use those trainer devices. And then we built a scenario around the use of this injector that we would run the students through, and we would collect data and we would talk to them about, what are some of the issues? What are some of the errors that we've seen? How long does it actually take to give this medication? And when you're educating patients and family members, what kind of strategies can you use to make sure that your patients and family members understand proper use and do this in a timely manner to get that medication delivered to the patient as soon as possible? So this was our scenario. Again, we kind of adapted this from John Gosby and others. So we had the scenario printed out for the students. We gave them the trainers, and then we would tell them, you're a pharmacy student, you're out with your friends enjoying coffee at a cafe, you start to feel tingling in your mouth and realize that the or I guess Becky starts to feel tingling and recognizes that she's having some anaphylactic symptoms. But now she's actually stopped breathing, and you're, her friend, and you need to figure out how to get the epinephrine autoinjector out of her bag and administer it. The friends, in this scenario are aware of that allergy. So they've got to give it quickly. The student retrieves the autoinjector, they administer the medication, and an observer collects data and interviews the participants thereafter. And so, some of the things that we found now we did this many times. Mostly we were doing this for educational purposes. So we were using this usability methodology to actually educate new nurses and educate pharmacy students when they were on rotations or in orientation. But here's some of the things that we would routinely see with this, especially with this original pen design, which when I first started doing this, that was the design that was available from the manufacturer at the time. So, thinking about operability of a device, it really comes down to the cues to the user about how it operates. Remember, in human factors, we talk about affordances. We talk about matching the real world or matching the system to what we expect in the real world, right? So there's lots of cues that give us information that might be misleading us, right? So do you press the button? Wait, where's the button? Looking at this device. Is this gray thing over here the button, or is this black thing over here the button, right? You need to remove the cap, but again, where's the cap? Is this black part the cap? Is this the cap? Where's the needle? Is the needle going to come out of this end, come out of this end? And ultimately, what we would see probably a quarter of the time is that people would take the pen and they would put it in their hand and they would press down on that black part. But unfortunately, that's where the needle comes out. And if you press down on it, a needle's going to shoot through your finger. It's going to inject you with epinephrine, and it's going to cause tissue necrosis, right, if this was really happening. So really can be problematic, this original pen design. The other thing that we would kind of build into our scenario is we just wouldn't put the pen in that student's bag, and then they would just be searching and searching, and they really didn't have kind of a good storage method for the pen as well. So again, another issue to be thinking about, especially with folks that are going to be educating patients, like nurses or pharmacists, for example. So one of the things this told us was we really needed to look at how are our nurses educating? Again, I worked in pediatrics, so how are our nurses educating our pediatric patients, many of whom, especially back then, had peanut allergies and other nut allergies, might have medication-related allergies that they needed an epinephrine autoinjector for. And so, it was very clear to us with the original design, or you can see here, this is the new pen design, that the design really did hinder human performance in many ways. Even the new design, still we would see errors with that new design. And so, again, that environmental use specifies the performance and requirements. So who needs to be able to do this? And again, for this, we needed family members to do this, or patients, or, maybe bystanders to be able to use this in kind of an emergency situation. Not everybody's going to be able to have training for this. And so usability testing can be really valuable in a process like this, where we're evaluating a device that has to be used in an urgent scenario. And so, designing devices that can be used without training is really important. But here's the thing. We weren't in a position to change the design of this device, right? That just wasn't an opportunity for us. We could, and certainly did submit feedback, especially, we would submit reports to ISMP if things went wrong at our institution. But for us at the time, kind of the best thing we could do is really think about how do we give high impact training to everyone. And so that's why we developed this document on the right. So another example of an operational method sheet, and we pretty much walked through the steps of what you need to do visually, and we would print these out and include these with discharge for these patients. So not exactly ideal, but in the scenario where you're not able to change that design, you've got to think about, how do you really optimize that design? How do you minimize human limitations and maximize human capabilities? The third example is a PCA pump example. And again, this is an example that was adapted from John Gosby. So in this scenario, patient-controlled analgesia devices were analyzed and ultimately redesigned. Now this was more at the vendor level, so less at the, like in the hospital setting, although they did perform these tests kind of in the actual setting, but really more kind of geared towards redesign of the actual device. There were two user populations. There were new nurses, so these were nursing students, and then recovery room nurses, which for PCA would be considered kind of an expert level, right? These nurses, these types of nurses program PCA pumps all the time. The scenario was, a specific PCA that needed to be programmed. And in terms of data that they gathered, number of errors. So they were directly observing the nurse and they were recording all errors that were detected during that programming process. They also looked at time to complete the task of programming the pump. How extensive was that? How long did it take? And again, this is actually published. It's a little bit old, but it is published and it's a good read as well. So as I mentioned, they did their original design and collected that data, made suggestions for redesign of the interface, implemented that, and tested that new design. And so looking at new versus the existing design, from a performance perspective, there were 50% fewer errors with the new design. This is huge. And even with the experienced nurses, there was actually an even bigger decrease in programming errors. Task completion was slightly faster as well in both groups. All right, so thinking about, how do you go about implementing usability testing in your practice? What are, some of the ways to kind of make this simple and really use this very effective tool for medication safety improvement? So some tips and tricks. Number one, recruiting participants who actually perform the task or use the technology in real life. I can't underscore this one enough. You really got to have people that understand how this works. Make sure you get enough users. So generally speaking, somewhere in the neighborhood of 5 to 10. We try to err more on the side of 10 participants if possible. But with that syringe pump user test that I shared, I think we had maybe 5 nurses in that, and I think we had maybe like 6 or 7 technicians, and it was fine. It really depends on the scenario how many people you need. Like I said, we had a more extensive scenario where we were evaluating procurement of new pumps, and we needed nurses from all over the hospital for that. So we had at least 30, maybe 40 nurses that participated. The observer needs to be skilled in observation techniques, data collection. It's really important that they don't bias the results. We try to minimize talking to the participant while they're doing the task. And this is really to avoid bias and, avoid kind of interference. And then, when they complete the task, as they're completing the task, you're collecting data. But at the end, you're almost always going to do some kind of user interview, generally with open-ended, very neutral questions. So this is the same slide that I concluded the heuristic evaluation lecture. And that's really by design because we use both of those methods sometimes together. As I mentioned before, in the kind of device and product procurement stage, maybe we do a heuristic evaluation and then we get user testing thereafter. Or maybe we just do, user testing right out of the gate for that. In the design and redesign, certainly, of health information technology devices and interfaces, cognitive aids, order forms, memory aids, checklists, training, just the actual training process, as well as the training materials like those operational method sheets that I showed you. So any of these things, these are all interfaces that user testing both heuristic evaluation and usability testing can be really useful for. User testing in particular is great for error analysis. So if you want to kind of figure out like what went wrong, how did the maybe how to replicate like what went wrong, you can do some user testing to see like what are all the possible scenarios. Sometimes you don't really know what went wrong in the actual error, but if kind of simulate that scenario, you might get some more useful information. Certainly during proactive assessments when we're evaluating solutions, and like I said, to test these changes broadly before implementing. All right, so our self-assessment. What kind of issues might be discovered utilizing usability testing during a safety analysis? And so problems with finding items or controls and displays, increasing time on that particular task, or a task that is kind of error prone, right? Because the way it's designed leads to errors that could cause harm. So these are all ways that user testing can be really useful during safety analyses. And in conclusion, usability testing can help find design problems with medication-related devices, as well as policies, processes. Usually policies and processes outline tasks that need to be done. And when I say medication-related devices, I mean this is kind of the full gamut of health information technology. Could be pumps, could be, EHR interfaces, could be actual devices like the epi auto injector that I showed you. I mean, really, there's just so many different interfaces that could be tested in the medication use process. Usability testing is considered the gold standard from the perspective of human factors engineering methods by many professional groups as well as international standards groups. So like I said, there is a rich history here in terms of organizations like the FDA requiring these kind of tests. And these are the references that were used to develop the presentation. And finally, thank you for your time and participation.